Okay, I think we're almost there, but I'm going to go ahead and just start out the public comment session by welcoming and thanking our public comment speakers for addressing the committee today. All the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For our speakers today, we have a limited public comment period, and in order to make it through all the listed speakers, it's extremely important that each speaker limits his, her, or their remarks to 3 minutes. We are displaying a timer on the screen so you know how much time you have left. And as a reminder, our committee appreciates diverse viewpoints that are respectful in nature and focused on the issues being discussed at our two-day meeting today and tomorrow. Thank you again to our speakers, and we look forward to your comments. Our first public comment speaker is Ms. Corinne Jones. Ms. Jones, are you online?
I'm sorry. Good afternoon. My name is Karen Jones, and I'm the president and CEO of the National Caucus and Center on Black Aging. We appreciate this committee's ongoing commitment to ensuring access to a wide variety of vaccines, especially in the wake of ongoing COVID-19 pandemic. However, I must use my time today to express my disappointment that this committee chose once again not to include clarification for the needed use of new adult vaccines for pneumonia. While these vaccines were approved last June by the FDA, the guidelines which were released by the CDC in January of this year did not provide clear guidance on whether older adults who had already received the pneumonia vaccine were eligible for the new and improved vaccines. This leaves 2/3 of Americans over the age of 65 uncertain of whether they too can have access to these new protections. As we continue to face respiratory threats with COVID-19 and the upcoming flu and pneumonia season this fall, why wouldn't we also take up the important step to ensure such a vulnerable population has access to the best protections available? While we certainly support the focus on ensuring that newest vaccines are available for children, we can't help but wonder why this can't be done at the same time as offering clarification for older adults as well. I have also previously shared comments with this committee on the importance of lowering the age-based recommendation for adult vaccines to those age 50 and over. In ACIP's June 2021 meeting, data was presented showing that this change would increase vaccinations among those living with risk of serious illness and therefore would likely to help address disparities in the uptake in these vaccines among minority populations, as well as provide cost savings to the system. This was incredibly encouraging, and yet we've not heard any further discussion on this proposal. Given that Black and Brown communities often experience the onset of chronic illnesses earlier than 65 due to environmental factors beyond their control and the effect of a lifetime of inequitable care, providing protection for these individuals earlier in life would not only offer earlier intervention for those at risk, but provide critical protections before immune system efficacy wanes as part of normal aging. We strongly encourage this committee to review any remaining data needed and provide clear guidance on the use of the pneumonia vaccines to ensure they are available to a full population of vulnerable Americans before the upcoming flu and pneumonia season. We also welcome the opportunity to continue discussions around the benefits of lowering the age-based recommendations to help close the disparity gaps and reduce the number of preventable deaths in this country. Thank you very much.
Thank you for your comment. Next, we have Kevin Tuttle. Please go ahead.
Hi, I'm Kevin Tuttle, the Public Relations Director for the Scherer family. I'll get to their story in a moment. No matter what I say to the ACIP board today, they'll ignore it like they've ignored grieving parents over vaccine injury for decades. We know this board has no conscience, but I'm not trying to reach them. I'm trying to reach those of you who know that something is up but can't figure it out. It's called genocide. Why have myocarditis, blood clots, Bell's palsy, infertility, and Gavin Newsom's favorite, GBS, skyrocketed since jabs got into arms warp speed? What about death? All-cause mortality was not higher in 2020 than 2019. Isn't that odd for such a deadly pandemic? But it's certainly higher since the COVID jabs came out. Must be those darn anti-vaxxers. Why are the jabs keeling over? Medical professionals are baffled, but they created a term, sudden adult death syndrome, SADS. This is history repeating itself. The 86 Childhood Vaccine Injury Act created a system that denies a link between vaccines and harm. When vaccine doses increased after that act, babies started dying and they called it sudden infant death syndrome, SIDS. See how that works? Died suddenly is all the rage these days amongst the jabbed, followed closely by half my face doesn't work. This criminal board won't address it and put an end to these toxic jabs because that would mean they're culpable for the deaths occurring. The AAP just announced updated infant sleep recommendations right after the jab was approved. Is that odd to anyone? This means they will blame parents for their child's death rather than look at the jab having caused the death. SIDS is about to explode and this board needs to be held accountable. This is genocide led by medical institutions and government. They did the same thing in Nazi Germany. Doctors worked for the regime. They would order dangerous medicines be given to the disabled, the useless feeders, and nurses would administer the deadly drugs. It was a government-planned, government-supported mass extermination of people. They could not have done it then without the support of diabolical physicians, scientists, nurses, and media, just like now. That's why they try to silence nonconformists like Doctors McCullough, Corey, and Paul Thomas, something Joseph Goebbels would have done in 1939. What was good for the state was more important than what was good for the individual, just like now. Nothing has changed despite the Nuremberg Code. Take Grace Sheriff, for example. Within a 29-minute window, she was given Precedex, lorazepam, and morphine without reason. She was 19. But Grace had Down syndrome, which was apparently enough for St. Elizabeth's Hospital, Ascension, in Appleton, Wisconsin, to designate her a useless feeder and kill her off through health care. Did Dr. Gavin Shokar know a max dose of Precedex could take Grace out? Is that why he submitted a DNR order on her without family consent 8 minutes after the sedative was given? This is the type of care one should now expect in hospitals. Avoid them at all costs. Let history be your guide. I was just doing my job, didn't fly in the Nuremberg trial. It won't fly for this board or those injecting people with this death shot at the next trial. Stop the genocide. Say no to all jabs, people. Thank you.
Thank you for your comment. Next speaker, Ms. Melina Berhaim.
Thank you, Dr. Lee. My name is Milana Berhane, and today I'm representing the National Consumers League. Since NCL's founding in 1899 by social reformer Florence Kelley, we have advocated for the critical role that immunizations play in the preservation and improvement of public health. We extend our gratitude to this committee for the opportunity to present public comment. According to the National Foundation for Infectious Diseases, pneumococcal disease is a leading cause of serious illness throughout the world. In the U.S., nearly 50,000 people die each year from pneumonia, and the death rate is even higher in those ages 65 years of age and older. Vaccination is a critical public health measure for preventing disease, hospitalizations, and deaths, so it is critical that access to the pneumococcal vaccine is expanded. We are concerned about the lack of clarity surrounding the current ACIP recommendations regarding the pneumococcal vaccine for adults ages 65 years of age and older. It is critical that the recommendations for this age group is clear so that patients and providers are better able to understand who should receive which vaccine and when. The pneumococcal vaccine will continue to be a safe and effective measure in protecting Americans from disease, and it is imperative that older adults are able to receive them. Having clear recommendations for adults 65 years of age and older is also critical in addressing health equity issues, especially among older Black and Latinx populations that already face issues in lacking access to health care. Pneumococcal vaccine uptake needs to increase in these populations so that the currently existing health disparities are not further exacerbated. Therefore, in order to promote health equity among all older adults and increase vaccination rates, it is critical that clear recommendations are provided for this age group. The National Consumers League recognizes the extreme importance of immunizations in protecting the health and safety of all Americans and will continue its efforts to increase vaccine confidence and uptake across lifespan. We look forward to the upcoming recommendations by this committee regarding the pneumococcal vaccine for older adults. Thank you.
Thank you for your comment. Next, we're going to move back up to Mr. Vangelis Rousseau.
Hello. Ready? There is no long-term safety data for COVID-19 vaccinations in young children. So vaccinating them is an experiment, and this experiment is not looking good. We already know that COVID vaccinated children 12 to 17 years old have a 5-fold increase in myocarditis. Those are not my words. Those are the words of Dr. Peter Marks from the FDA. Currently, about 1.3 million injuries have been reported to VAERS for all age groups. This includes anaphylactic shock, allergic reactions, blood clotting, and other bleeding disorders, myocarditis, pericarditis, stroke, heart attacks, tinnitus, death, and more. Some children will die, and others will be permanently injured from these shots. Why should children be forced to take this risk when they have a 99.995% recovery rate, which means that almost 0 kids have died from COVID-19? In February 2022, the CDC said over 75% of children already have partial or full immunity to COVID. COVID vaccines do not stop transmission or infection. There is no statistically valid evidence that they prevent severe disease or death in children. The current COVID vaccines were formulated based on the original Wuhan strain and were not tested for benefit against current variants in clinical trials. These vaccines are not science-based medicine. They are neither safe or effective. In fact, Pfizer's clinical trial for 2 to 4-year-olds failed to meet FDA requirements to show 50% efficacy. The vaccine failed the FDA's established criteria in its clinical trials. This is clearly not about science and facts. So what is it about? If we don't stick to the facts and science, this will lead the public into thinking something more nefarious is going on. Is it? COVID is not a public health threat. You know what the real health threat is? People in the position to protect the public that do not. So I want to ask if any of you have the courage to be real scientists. You actually have a chance to be true heroes. The facts clearly show that this vaccine will do more damage than it will prevent. So why are you doing it? So you actually have a chance to be true heroes. So now is the time to be remembered in history as a hero, or you could be remembered as a coward. The choice is yours. Thank you.
Thank you for your comment. Next, we'll move to Ms. Itzia Iranio.
Hi, yes, good afternoon.
Yes, please go ahead.
Okay. Yes, so I just wanted to, my comment is going to be very quick. Why are we giving this injection to especially kids that are 5 years and under when clearly their immune system and brains isn't fully developed? That's my question. And number 2 is, most vaccines take to 10 years to get approved by the FDA. And why are we giving this injection still when it's under EUA? And that's all.
Thank you for your comment. Next, we'll move to Robert Blancato.
Members of the committee, my name is Bob Blancato, Executive Director of the National Association of Nutrition and Aging Services Program. NANASP appreciates the opportunity to submit an oral comment. As I have done in my prior testimonies, I start by commending ACIP for your hard and dedicated work throughout this pandemic. I join my colleague Karen Jones and offer my comment to specifically register our deep disappointment in the failure of this committee to include any discussion or action on clarifying current CDC guidance on older adults having access to new and improved pneumococcal vaccines on the agenda, including all those over 50. NANASP was joined by several other national aging, patient, and healthcare organizations in petitioning ACIP to include this discussion on the June agenda. In fact, we also specifically wrote to 4 ACIP members, all of whom expressed some sympathy with our request. At the heart of the matter is that under the current guidance, only those older adults who have never received a pneumococcal vaccine are eligible to receive the new vaccines. The rationale as provided in an email from Melissa Wharton was that, quote, the greatest benefit from the new pneumococcal vaccines now will be in adults who have not yet received pneumococcal vaccines, unquote. Overlooked by this rationale are the 67% of older adults who have already received a pneumococcal vaccine who have no access to this new vaccine. Also overlooked how long it may have been since some of these older adults received their first vaccine. And given that we know the strength of the immune system wanes as individuals age, ensuring access to improved versions of the vaccine, which protect against more strains of disease, is a critical and greater level of protection that we should not be denying older Americans. We should never forget that older adults had a disproportionately higher death rate from pneumococcal pneumonia than other groups. Their vulnerability is genuine. Our main point is that CDC should consider the benefit that access to these new vaccines for all older adults would have. Our nation's healthcare system can walk and chew gum at the same time. It is possible to both vaccinate older adults who have already received vaccines and those who have not. Older adults who were previously vaccinated should not be penalized for having done the right thing already. We implore members of ACIP to clarify this guidance by recommending these new and improved pneumococcal vaccines be made available to all older adults, previously vaccinated or not. That is the most equitable approach. We thank the committee for considering our comments.
Thank you for your comments. And I want to thank all of our public comment speakers today for coming forward. And we are ready to move on to the votes for today. So I will go in order that's on the agenda. First, we have the influenza vaccine vote. I'm going to ask if Dr. Lisa Groskopf can, or somebody in the room can please bring up the vote language that was put on the table as a motion and seconded. Thank you. So this is influenza vote number 1. Oh, before we get started, I'm going to just ask people before we hit each vote if they have any additional questions or issues that you'd like to discuss before the vote. And since we have a series of votes, we're going to go ahead and ask ACIP members to please turn on your video. When you are asked to give your vote, we'll ask you to state your name, whether you have a conflict of interest, and then your vote. If you would like to make a statement, I'm going to ask if we can do that at the end of the series of votes. So feel free to make a statement on any of the votes at the very end, but I would like to get through the votes we have on the table today. So our first vote is the influenza vote, influenza vaccination for persons aged 65 years and older, with the language there on the slide. Are there any questions or additional issues the committee needs to discuss before we move to vote? I don't see any hands raised. So I'm going to assume the committee has no objections to proceeding with the vote. And as my members know, I'm going to call you out of order, so just be prepared. We're going to start today with vote number 1 for influenza with Dr. Jamie Lair.
Dr. Jamie Lair, no conflict. I vote yes.
Thank you. Dr. Sineas.
Dr. Sybil Sineas, no conflicts, yes.
Thank you. Dr. Chen.
Wilbur Chen, no conflicts, yes.
Thank you. Dr. Payne.
Kathy Paling, no conflict, yes.
Thank you. Dr. Talbot.
Dr. Talbot, no conflict, yes.
And I didn't hear a yes or a no. You might have muted too soon.
Oh, I was so excited I cut myself off. Yes.
Thank you. Ms. Bata.
Lynn Bata, no conflicts, yes.
Thank you. Dr. Alt.
Alt, no conflicts, yes.
Thank you. Dr. Bell.
Sorry. Okay. Oh, there we are. Okay. Sorry. Bell, no conflicts. Yes.
Thank you, Dr. Bell. Dr. Brooks?
Oliver Brooks, no conflicts. Yes.
Thank you. Dr. Long?
Sarah Long, no conflict, yes.
Thank you. Ms. McNally?
McNally, no conflicts, yes.
Yes. Okay. Thank you. Dr. Sanchez?
Sanchez, no conflict, yes.
Thank you. Dr. Daly? Dr. Daly, I can't hear you, sorry. It might have been me. Does anyone hear Dr. Daly? No, okay, Dr. Daly, I'll come back to you in a moment. Dr. Cotton.
Emil Cotton, no conflicts, yes.
Thank you. Lee, no conflicts, yes. Dr. Daly.
Matt Daly, no conflicts, yes. Did you hear that?
We did hear that. Thank you very much. So, Dr. Wharton, this influenza vote for vaccines for persons aged 65 years and older passes with 15 yeses and 0 nos. Thank you, everybody.
Thank you.
Next, we'll move on to the next vote. So influenza vote number 2. I'll just read it really quickly. Affirm the updated MMWR recommendations and reports, prevention and control of seasonal influenza with vaccines, recommendations of the ACIP United States 2022 to 23 influenza season. Any issues or other points raised for discussion before proceeding with the vote? Okay, I see lots of shaking heads. So we're going to go ahead and proceed with the vote, and we're going to start with Dr. Chen.
Wilbur Chen, no conflicts, yes.
Thank you. Dr. Daly.
Matt Daly, no conflicts, yes.
Thank you. Dr. Cotton.
Emil Cotton, no conflicts, yes.
Thank you. Dr. Paling.
Kathy Paling, no conflict, yes.
Thank you. Ms. McNally.
McNally, no conflicts, yes.
Thank you. Dr. Bell.
Bell, no conflicts, yes.
Thank you. Dr. Alt.
Alt, no conflicts, yes.
Thank you. Dr. Long.
Sarah Long, no conflict, yes.
Thank you. Ms. Bata.
Lynn Bata, no conflict, yes.
Thank you. Dr. Talbot.
Dr. Talbot, no conflict, yes.
Thank you. Dr. Sineas.
Sybil Sineas, no conflicts, yes.
Thank you. Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Thank you. Dr. Lair.
Jamie Lair, no conflicts, yes.
Thank you. Dr. Sanchez.
Bill Sanchez, no conflict, yes.
Thank you. And Lee, no conflicts, yes. So Dr. Wharton, this vote number 2 for influenza vaccines also passes with 15 yeses and 0 nos.
Thank you.
Thank you. All right. We will move on to the next vote, which should be pneumococcal vaccines. Thank you. So the pneumococcal vote, PCV 15 may be used as an option to PCV 13 for children aged less than 19 years, according to the currently recommended PCV 13 dosing and schedules. Are there any concerns or additional questions the committee would like to raise for this vote? I see lots of shaking heads again. Thank you. I'm going to make it easy for you this time. I'm going to go in alphabetical order so you can know when you're going to say vote. So we are going to proceed with a vote for pneumococcal vaccines PCV 15 and ask Dr. Alt to start us out.
Alt, no conflicts, yes.
Thank you. That was a yes. Ms. Bata.
Lynn Bata, no conflict, yes.
Thank you. Dr. Bell.
Bell, no conflicts, yes.
Thank you. Dr. Brooks.
Oliver Brooks, no conflicts, yes.
Thank you. Dr. Chen.
Wilbur Chen, no conflicts, yes.
Thank you. Dr. Sineas.
Sybil Sineas, no conflicts, yes.
Thank you. Dr. Daly.
Matt Daly, no conflicts, yes.
Thank you. Dr. Cotton.
Emil Cotton, no conflicts, yes.
Thank you. Dr. Lair?
Jamie Lair, no conflicts, yes.
Thank you. Lee, no conflicts, yes. Dr. Long?
Sarah Long, no conflict, yes.
Thank you. Ms. McNally?
McNally, no conflicts, yes.
Thank you. Dr. Paling?
Paling, no conflict, yes.
Thank you. Dr. Sanchez?
Sorry. Pablo Sanchez, no conflict, yes.
Thank you. And Dr. Talbot?
Talbot, no conflicts, yes.
Thank you. So, Dr. Wharton, this vote for pneumococcal vaccines passes with 15 yeses and 0 noes. And my question to you is, I believe we do have a VFC vote, so I wanted to ask Dr. Wharton and Dr. Kobayashi if you'd like to go ahead and do that now or after the additional vote. Oh, here we go. Go ahead. Oh, Dr. Santoli, is that you this time?
Yes, that's me.
Please go ahead, Dr. Santoli. Thank you. We'll take a brief moment for Dr. Santoli to present, and then we will proceed with a VFC vote that we need to put.
Great, thank you. Next slide. Thank you. So the purpose of this resolution is to update the recommendations regarding the use of pneumococcal conjugate vaccines to include PCV15 as an option. You'll note just as we walk through this, the resolution has two components, the PCV component and the PPV V23 component. Both of them have been updated to reflect the inclusion of PCV15, and you'll see that changes are either in yellow font or yellow highlighting. Next slide. So the eligible groups for the PCV component of the resolution are unchanged. Next slide. The table, however, is slightly different. We've grouped together two of the categories in this table that had previously been in a separate category called functional and anatomic asplenia. They're now included under the immunocompromised persons category. Otherwise, the table is the same. Next slide. Here you see PCV 13 has been replaced with PCV in order to reference PCV 13 or PCV 15. You see that in numerous places. It's highlighted. Next slide. Here you see there was a little bit of a clarification to be clear around what was an incomplete schedule. So the wording is just aligned with the ACIP recommendations. Next slide. And then the table notes, of course, the first table note reflects PCV 15, and for slide table note 4 has been added, again, to clarify what is meant by the text in the table. I'll give you a minute to look at that. Next slide. The recommended dosages and the contraindications and precautions have not changed, although we will be adding the PCV 15 package insert prior to posting this resolution under contraindications and precautions. Next slide. For the PPSV 23 component, the only change in the eligible groups, again, is Table 1, which we saw a few slides back. It's also referred to in this component of the resolution. Next slide. And here again, reference to PCV has been updated to be inclusive of PCV 15. Next slide. There are no changes to the recommended dosages or contraindications and precautions. Next slide. And this is just a statement about published recommendations that are incorporated into the resolution by reference if they're published within the next 12 months. And that concludes the VFC resolution update.
Thank you very much, Dr. Santoli. May I ask for you to put up the slide with the vote language that you'd like us to consider?
So there's not separate language. It's really voting on these updates to the resolution that we walked through.
Okay. Are there any questions for Dr. Santoli? Ms. Bata?
I don't have a question. I was going to move to adopt the updated language in the pneumococcal VFC resolution.
Okay, thank you. I appreciate that. There's a motion on the table. Do I have a second? Dr. Alt?
I will second the motion.
Dr. Lee, I think you're muted.
Thank you. It was I was muted for quite a while. So I think I said I was saying that I wanted to thank you for moving and seconding that we have this motion on the table to vote on the VFC recommendations for pneumococcal vaccines. And are there any additional questions or concerns individuals would like to raise? Okay, I don't see any hands raised. So we will proceed with the VFC vote and the updates that were presented on the slides by Dr. Santoli. So I'm going to go in reverse order today, just to give you a heads up. So we're going to start with Dr. Talbot.
Dr. Talbot, no conflict? Yes.
Thank you. Dr. Sanchez?
Otto Sanchez, no conflict? Yes.
Thank you. Dr. Paling?
Paling, no conflict? Yes.
Thank you. Ms. McNally?
McNally, no conflicts? Yes.
Thank you. Dr. Long?
No conflict. Sarah Long, no conflict? Yes.
Thank you. Dr. Lair?
Jamie Lair, no conflict? Yes.
Thank you. Grace Lee, no conflicts? Yes. Dr. Cotton?
Camille Cotton, no conflict? Yes.
Thank you. Dr. Daly?
Matt Daly, no conflicts? Yes.
Thank you. Dr. Saneas?
Sybil Saneas, no conflict? Yes.
Thank you. Dr. Chen?
Wilbur Chen, no conflicts? Yes.
Thank you. Dr. Brooks?
Oliver Brooks, no conflicts? Yes.
Thank you. Dr. Bell?
Bell, no conflicts? Yes.
Thank you. Ms. Bata?
Lynn Bata, no conflict? Yes.
Thank you. Dr. Alt?
Alt, no conflicts? Yes.
Thank you. So Dr. Wharton, the VFC vote passes to 15 yeses and 0 noes. Thank you, everybody. Shall we move on to the next vote? I believe we have one more vote. Thank you. MMR vaccines. I'm just going to read it quickly. The MMR vaccine, Priorix GSK, is recommended according to currently recommended schedules and off-label uses as an option to prevent measles, mumps, and rubella. So are there any questions or clarifications needed before we proceed? There are no hands raised, so I'll assume there are no objections to proceeding with a vote. I am going to go out of order. So if everyone could be prepared, we're going to start with Dr. Cotton.
Camille Cotton, no conflict? Yes.
Thank you. Dr. Saneas.
Sybil Saneas, no conflict? Yes.
Thank you. Dr. Long.
Sarah Long, no conflict? Yes.
Thank you. Dr. Bell.
Bell, no conflicts? Yes.
Thank you. Dr. Alt.
Alt, no conflicts? Yes.
Thank you. Dr. Paling.
Paling, no conflict? Yes.
Thank you. Dr. Chen.
Wilbur Chen, no conflict? Yes.
Thank you. Dr. Talbot.
Kip Talbot, no conflict? Yes.
Thank you. Ms. Bata?
Bata, no conflict? Yes.
Thank you. Dr. Sanchez?
Pablo Sanchez, no conflict, yes.
Thank you. Dr. Brooks?
Oliver Brooks, no conflicts, yes.
Thank you. Ms. McNally?
McNally, no conflicts, yes.
Thank you. Dr. Daly?
Matt Daly, no conflicts, yes.
Thank you. Dr. Lair?
Jamie Lair, no conflicts, yes.
Thank you. And Grace Lee, no conflicts, yes. So Dr. Wharton, our last vote on MMR vaccine passes with 15 yeses and 0 nos.
Great. Thank you so much.
Thank you, everyone. I don't believe we have any additional votes after this, so I'll just pause for a moment and ask if anyone would like to make a comment, and I see on any of the vaccine votes. Dr. Talbot, please go ahead.
Yeah, I am super excited today that we are improving vaccination for older adults, and was super excited to see during the comment section so many seniors and senior groups advocating for vaccines. Really, the prevention of hospitalizations and reducing the time of disability and improving life is incredibly important in our seniors who are a growing population. Along those lines, I would like to say that these influenza vaccines are better, but are not yet the home run that we would love to have. And so I would like to encourage our current vaccine manufacturers to continue to try to find that holy grail of an influenza vaccine that will work every time and will work for our older immunosuppressed patients. So thank you for everyone's vote today, and thank you for looking out for our seniors. And the groups who are advocating for older adults, please continue. Thank you very much.
Thank you. Dr. Cotton?
I'd like to second what Dr. Talbot just said, and it's wonderful that we have this recommendation for the influenza vaccine for people, for older folks. I would like to highlight that the immunocompromised patient population still remains very vulnerable to influenza, and although the data for that population isn't as robust, hopefully in the near future we can also make a recommendation for that population to undergo some of these likely improved and better vaccines and provide them with better protection. As it stands right now, because these aren't recommended, they usually are not covered by insurance. So some of my patients have had to pay out of pocket, which ends up quite expensive, and it's obviously off-label use of vaccines. So hopefully that will be the next frontier. Thank you.
Thank you, Dr. Cotton. Do any other ACIP members wish to make a statement?
You're on mute.
Dr. Lee, you were muted for a moment.
Sorry. Okay. I don't see any other ACIP members' hands raised, but I do see Ms. Stinchfield's hand is raised. So would you like to make a statement, Ms. Stinchfield?
I would. Thank you, Dr. Lee. I hear you. I am Patsy Stinchfield from NAPNAP, National Association of Pediatric Nurse Practitioners. Just want to say two things quickly. I'm on both the influenza work group and the MMR work group and the RSV work group, but today you saw so much data, and I just wanted to publicly say thank you to the CDC staff. The work behind the scenes is phenomenal. The amount of rigor in the evidence to recommend framework, the respect, the thoroughness, the inclusiveness of those who are not part of the CDC is really, really commendable. And I just want everyone in the vaccine arena of CDC to know how much you are valued. The second thing I wanted to say, thank you, Sarah, for the applause. The second thing I want to say is the MMR additional option is so good, and we have to put them to use. Our MMR vaccine coverage rates in the U.S. were already low before the pandemic and are dropping for a number of reasons, misinformation being one of them. I'm very concerned about our next outbreak being measles. We've already seen 2 cases in Minnesota, including a hospitalized child after international travel, who the hospitalized child did get vitamin A as per good guidelines. So just want to encourage everyone to really make sure that we are doing reminder recall and getting these kiddos back in. Thanks so much.
Thank you very much. And I know all of us appreciate very much all of the work the CDC staff are doing, and it seems to never end. We continue to move forward. I think we are ready to take a break. I would like to take a longer break, and I'm just going to poll the members real quick. 15, 20 minutes. We plan to reconvene at 20 minutes after the hour. Is that okay? Any objections? Okay, 20 minutes after the hour, we'll reconvene. Thank you so much.